So as we continue with our hemodynamic sessions, this presentation is going to be about different hemodynamic manipulators. We'll start with fluids, then talk about the vasoactive medications, including the inotropic agents, then the volume offloading interventions, and we conclude with a suggested flowchart for the management of a shock state. But first, let's discuss again the autoregulation mechanism. And as you know, the equation that dictates the relationship between the flow, pressure, and resistance is that the flow equals pressure divided by resistance. Now, if we have on the x-axis the perfusion pressure and on the y-axis the blood flow, without any autoregulation mechanism, we're going to see a direct relationship between the perfusion pressure and the blood flow. If the vessels were constricted, you will see that the blood flow increases gradually as we go up on the perfusion pressure. That increase in the blood flow will be much higher if the vessels were dilated. Well, the fact that we have autoregulation, this mechanism maintains stable blood flow in vital organs such as the brain and the kidneys. So let's see what happens if we have autoregulation. We're looking at the red line here. As you see, the middle part of the line is maintaining same blood flow or changing perfusion pressure. So if the perfusion pressure is decreased, the blood flow is maintained the same. How is that possible? If you take a look on the equation here, perfusion pressure is decreased. The only way the flow remains the same is by decreasing resistance. That means that the vessels are vasodilated as the perfusion pressure goes down. Now we get into a critical point where decreasing the perfusion pressure is not going to be associated with the same blood flow. The reason being is that the resistance cannot be decreased any further. The vasodilatation is at the maximum, and any further decrease in the perfusion pressure will result into a decrease in the blood flow. At the same time, if the perfusion pressure is increased gradually, the vessels will be vasoconstricted to maintain the same blood flow. However, we reach a point where the vasoconstriction is at its maximum and cannot be increased anymore. At that time, the increase in the perfusion pressure will result into an increase in blood flow. It is very important to understand this because this is a situation in a healthy state. Now we will see that in critically ill patients, this autoregulation is disrupted and there is a direct relationship between the perfusion pressure and the blood flow, and we'll see that the blood flow would decrease if there's a decrease in the perfusion pressure. So the body is autoregulated to maintain perfusion and perfusion pressure. When autoregulation is lost, then the flow will rely on the presence of adequate pressure. And autoregulation is commonly disrupted or lost in any critical illness. Now, in terms of fluid types, we have two main types of the fluids, either crystalloids or colloids. Crystalloids fluid move freely through semi-permeable membranes. They contain stable solutes. They have a long shelf half-life, and they distribute quickly into body compartments in equilibration. And they are inexpensive except for the plasma light. Crystalloids could be either balanced or non-balanced. Balanced crystalloids such as plasma lights, Ringer's lactate. The non-balanced are mainly the sodium chloride, 0.9%. And those could be also classified based on the chloride content to either chloride poor, such as Ringer's lactate or plasma lights, or chloride rich, such as sodium chloride. They can also be classified based on the tonicity, with isotonic being similar to the plasma osmolality, and this is what we have with the sodium chloride. Hypertonic crystalloids such as 3% saline, and the hypotonic lower than the plasma tonicity such as dextrose water, the 0.45 saline. Now, the fluids are distributed in different compartments, and there are certain rules that dictate what is the percentage of each individual fluid to be distributed among different compartments. Most of the balanced crystalloids will stay in the extracellular compartment, compared to the glucose water, which will mainly go into the intracellular compartment. So it is ideal for treating intracellular dehydration. Now, in general, 60 to 70% of the body weight is water. 2/3 of the total body water is inside the cells or intracellular compartment, and 1/3 is the extracellular compartment, which contains two different compartments: the intravascular compartment, which is 25% of the extracellular compartment, and you have the interstitial compartment, which includes the bone and connective tissue, in addition to the interstitium, lymphatics, and the transcellular. Now, when you give a colloid, such as albumin, essentially the majority of the colloid will be confined into the intravascular space or compartment. So almost 90 to 100% of the colloid will be intravascularly and will expand the intravascular volume. If you give 1 liter of balanced crystalloids, that will be distributed between the interstitial compartment and the intravascular compartment. And the percentage is usually 18% intravascularly, and the remaining will be interstitial in the interstitial compartment. If you give normal saline, it will be distributed equally between the intravascular compartment and the interstitial compartment. And since the interstitial compartment is almost 75% of the whole extracellular compartment, thus the normal saline will be distributed at 25% intravascularly and 75% extravascularly in the interstitial compartment. So that means that 200 out of the 1 liter, 200 to 250, will remain intravascularly, and 750 to 800 will be in the interstitium. Now, if you give 1 liter of glucose, the glucose will move freely among the 3 compartments: intravascular, interstitial, and intracellular. And they will be distributed at the same percentage of these compartments, meaning that 1 liter of D5W will be distributed into the intracellular compartment with about 600 ml, interstitial about 320, and the remaining will be intravascular. So the best solution for expansion would be colloids, followed by the saline, and then the least fluid that is suitable for expansion would be the glucose 5%. If you have a patient with intracellular dehydration, glucose 5% would be the ideal fluid for rehydration. It's also important to understand the electrolyte composition of different body fluids. So for example, the sweat would have 65 millimole per liter of sodium, compared to gastric is about 20 to 100. What does it mean? If we lose 1 liter of fluid through sweats or gastric content, we're going to lose more water than electrolytes or than sodium. That means the patient is going to end up with hypernatremia with dehydration. Compare this to the content of the bile or the ileum, ileal fluid. The sodium content is higher. In the bile is up to 150 millimole per liter. What does it mean? It means that if we lose 1 liter of bile, we're going to end up losing more sodium than water. That means the patient is going to be dehydrated with hyponatremia. Same principles can apply to a different type of fluids that we lose from the body. And then you need to understand that the effect of the tonicity on the red cells. If you have hypotonic fluid, you're going to cause lysis of the red blood cells. You're going to maintain the shape of the RBCs with isotonic fluid, and the RBCs will be shrinked with hypertonic fluid. On the other hand, colloids are solutions that contain water with insoluble particles and form suspension rather than solution as it is in crystalloids. We have 2 different types of colloids, either the natural colloids such as the human albumin, and the other type is the semi-synthetic products such as dextrans, gelatins, and hydroxyethyl starches. Of course, all this have proven that they associated with worse outcome in critically ill patients, and we don't use them anymore, mainly causing increased rate of acute kidney injury. In practice, if you have a patient that you're questioning whether there's hypovolemia or not, if it is clear that the patient is hypovolemic based on your clinical assessment and examination, at that time you just give fluids. If the patient is clear that he's not hypovolemic based on your clinical assessment and physical examination, at that time you do not give fluid. However, if you're not sure, at that time you need to do fluid challenge. And fluid challenge can be done through either mini fluid challenge. You can do 4 ml per kg of fluid and assess, or you can do passive leg raising that we're going to be talking about in fluid resuscitation. And finally, you can rely on the dynamic tests that rely on the relationship between the heart and the lungs, or the heart-lung interaction principles. In general, the volume of the fluid that we utilize for resuscitation is a bolus of 4 ml per kg over 15 to 30 minutes. We're going to see in our resuscitation presentation how this is compared to many challenges, and we'll see the different studies that showed the outcome of either 4 ml per kg versus 1, 2, and 3 ml per kg. Now, in general, the fluid type for maintenance is balanced fluid, meaning that we like to use ringer lactate instead of normal saline. And you should remember that when given fluid challenge, the lack of clear effect does not mean lack of benefit. So if you determine that your patient does not seem to be fluid depleted, at that time, it doesn't mean that the patient is not going to benefit from the fluid. Moving to the vasoactive medications, and those are mainly the beta-1 stimulators such as dobutamine, epinephrine at a low dose, or norepinephrine. And those are mainly agents that increase the cardiac output and the heart rate. Then we have the vasoconstrictors that are stimulator for alpha-1, such as phenylephrine, norepinephrine, and epinephrine. And then we have the beta-2 stimulator, such as dobutamine and dopamine at low dose. And we have the phosphodiesterase inhibitors, such as mirinone. And then we have the isoproterenol. Of course, the dopamine at a low dose acts on the dopaminergic receptors. So here we have all the vasoactive medications classified based on their inotropic effects and on their peripheral vascular effects. So the upper boxes, we have agents that are vasoconstrictors. The bottom one are vasodilators. On the left, we have agents that have direct inotropic effect, and on the right, we have agents that do not have inotropic effects. So the agents that have vasoconstriction effect and inotropic effects are called inoconstrictor, such as norepinephrine, epinephrine, and dopamine. Now, agents that have vasoconstriction effects but no inotropic effects are vasoconstrictors, such as phenylephrine and vasopressin. If we have vasodilatation effects with inotropic effects, those are inodilators, such as dobutamine, mirinone, and levosimendan. On the other hand, agents that do not have any inotropic effects but are vasodilators are called vasodilators, such as nitroglycerin, nitroprusside, or nesiritide. You can see these agents also on this graph here nicely. On the y-axis, we have the effect on the vessels. Below the x-axis, vasodilatation. Above it, vasoconstriction. On the x-axis, we have the positive inotropy. So we start with agents that have zero inotropic effects but are vasoconstrictors, such as phenylephrine, which is stronger than vasopressin. On the other hand, we have nitroprusside that has no inotropic effect but pure vasodilatation. If you move this way here, we start seeing, in addition to vasoconstriction, we have inotropic effect with the norepinephrine. So it's a good vasoconstrictor, but also has an inotropic effect. Moving to epinephrine at low dose, the medication has minimal vasoconstrictive effect, but has remarkable inotropic effect. Dopamine is an agent that has both vasoconstriction and inotropic effect, and high-dose epinephrine has the highest inotropic effect with vasoconstriction at the same time, but it is lower than norepinephrine in terms of vasoconstriction. Now, the agents that have inotropic effect and vasodilatation, we have dobutamine that has a higher inotropic effect than milrinone. But milrinone has more vasodilatation effect compared to dobutamine. And we'll start with the norepinephrine. As we mentioned, it is a powerful vasopressor via alpha-1 receptors. It is the drug of choice to raise mean arterial pressure, including undifferentiated shock. If you're not sure what kind of shock you're dealing with, norepinephrine is the drug of choice. It has a minimal beta-1 effect. The dose is 0.01 to 1 microgram per kg per minute, and there's no maximum dose, but I usually do not go above 1, rarely above 1. Rarely up to 1.5 microgram per kg per minute. Survival rate is very low with any dose above 1 mics per kg per minute. The agent is 100 times more potent than dopamine and 3 to 5 times more potent than phenylephrine. Of course, you need a central line, but can be used for a short period of time at a low concentration through peripheral line, with caution till you get the central line placed. So please do not delay the start of norepinephrine if you don't have central line. You can start peripheral line and then insert the central line later. And this study shows the outcome of patients with sepsis in relation to the arterial pressure. So you can see here, the longer the patient spent time with mean arterial pressure below 60 millimeter mercury, the higher the mortality. So mortality is around 20% if that mean arterial pressure below 60 is only for 0 to 4 hours. And you can see that it goes up all the way to above 80% if that mean arterial pressure of less than 60 is the duration of that mean arterial pressure is 20 to 24 hours. And this is 28-day mortality. And when you give a vasoactive agent, you need to determine the target mean arterial pressure. And we usually target mean arterial pressure between 60 and 65. In a normal person, any pressure higher than 65 is not going to be associated with better organ blood flow, because we're in the autoregulation segment of the graph. However, in patients with hypertension, where the autoregulation is, or the whole graph is shifted upward and to the right, we may need higher mean arterial pressure in order to maintain the adequate blood flow to the organ. And this is only in patients with hypertension, history of hypertension, and uncontrolled hypertension. On the other hand, a mean arterial pressure of less than 60 millimeter mercury is going to be associated with decreased blood flow, because you're outside the autoregulation and no more vasoconstriction, no more vasodilatation is going to be able to maintain the blood flow for the organ. So we make sure that the mean arterial pressure is at least 60 millimeter mercury or above. What is the maximum dose of norepinephrine, if any? Well, we have a study that was published in 2017 and showed the outcome in relation to the dose of the norepinephrine. Now, in this study, it was shown that patients with higher dose of norepinephrine above 0.75 microgram per kg per minute are associated with worse outcome compared to those patients who required norepinephrine at dosages less than 0.75 mics per kg per minute. However, when this is actually plotted against how many organs do we have, how many dysfunction organs do we have, or in other words, the SOFA score, when the SOFA score was above 10, the mortality rate was very high at 86%, compared to those patients who required higher amount of norepinephrine but had SOFA score of less than 10, they had mortality rate of 58%. So actually, yes, we use higher dose norepinephrine. If the SOFA score for those patients less than 10, the mortality rate is much better than if the SOFA score is higher than 10. Epinephrine at a low dose, 0.01 to 0.1, is a stimulator for the beta-1 receptors and causes increased cardiac output. At a higher dosages, it stimulates alpha-1 receptors and causes vasoconstriction. Of course, it increases the heart rate, the temperature, blood glucose, and blood lactic acid level. Epinephrine should only be added to norepinephrine in cases of refractory shock. It is a second-line agent because of its metabolic side effects. Again, there is no maximum dosages, but usually we do not go above 1 mics per kg per minute. It certainly needs a central line to be placed. However, you can use it peripherally. Since it is a second agent, most of the time you already have the central line in place because you used norepinephrine, and you maximize the use of norepinephrine before you added the epinephrine. Dopamine at a low dose, less than 4 to 5 mics, stimulates dopaminergic receptors and causes splanchnic vasodilatation and increased renal blood flow. At a moderate doses, 5 to 10 mics per kg per minute, it stimulates beta-1 receptors and increases cardiac output. When the dosages are more than 10 to 20 mics per kg per minute, at that time vasoconstriction is the result of stimulation of alpha-1 receptors. And of course, 1/3 of shock patients fail to respond to dopamine. It is not an agent that we use for septic shock patients. It is inferior to norepinephrine and causes increased mortality, especially in patients with ischemic heart disease. The agent can be initiated peripherally, and the main side effect is tachycardia. If you have neurogenic shock, it's an agent that you can utilize. This is a study that, or the meta-analysis that compared use of norepinephrine to dopamine in patients with septic shock, and clearly norepinephrine is favored for patients with septic shock over dopamine. There's an absolute risk reduction of 11% with the use of norepinephrine, and the number needed to treat was 9 patients. Phenylephrine is a potent pure vasopressor, and it stimulates alpha-1 receptors. Phenylephrine has a duration of action up to 20 minutes. Therefore, we can utilize the agent as a bolus administration in patients with abrupt onset of vasodilatory hypotension, such as after RSI with intubation. You can give one dose of epinephrine, 100 mics, and you can boost the blood pressure. The maximum phenylephrine dose is 2 mics per kg per minute. This is to avoid excessive vasoconstriction, but in real life you can go actually up to 8 mics if you added this agent in a refractory shock. This agent is not preferred because of its potent vasopressors, and it can cause ischemic consequences in the limbs. At a lower concentration, it can be infused through peripheral line, but also for a short time. Phenylephrine is not recommended for septic shock except when norepinephrine is associated with arrhythmias or in the setting of persistent hypotension and high cardiac output. Vasopressin exerts its vasopressor properties through the stimulation of V1 receptors. It is fixed dose. Usually we use 0.03 units per minute. Since the V1 receptors are distributed in heterogeneous way, hence the effect of vasopressin on various blood vessels is heterogeneous too. The agent does not cause increase in the heart rate compared to norepinephrine, so it is preferred in patients with tachycardia. The endogenous vasopressin is usually depleted within a few days after the onset of septic shock, which makes the use of it very appropriate at that time. Dobutamine acts on beta-1 and beta-2 receptors. It has a minimal alpha-1 receptors, alpha-1 activity at a high dosages above 15 mics per kg per minute. The agent stimulates beta-1 receptors and increases stroke volume, heart rate, and cardiac output. Since it is stimulator for beta-2 receptors, thus it is a good vasodilator agent. Particularly at lower dosages of less than 5 micrograms per kg per minute. But the recommended dose is 2 to 20 micrograms per kg per minute, and we start at low dose and increase gradually. Usually, we have a cardiac output monitoring device to see the effect of dobutamine and titrate the dose. Of note, you should be careful when you use dobutamine because tachyphylaxis may occur after 72 hours of continuous infusion. Then Mirinon augments the downstream of beta-1, beta-2 signaling by inhibiting phosphodiesterase 3. It produces prominent pulmonary and systemic vasodilatation, so it is an agent that is preferred in patients with pulmonary hypertension, as Mirinon reduces pulmonary vascular resistance more than dobutamine. Mirinon is the preferred agent for patients with chronic heart failure, especially in the presence of pulmonary hypertension, right ventricular failure, or beta blocker therapy. It is contraindicated in patients with renal failure due to risk of accumulation. Mirinon is usually used at a dose of 0.375 up to 0.75 microgram per kg per minute in acute heart failure. The agent causes significant hypotension, especially in hypovolemic patients. We don't use levosimendan in our practice, but it is an inodilator. It's a calcium sensitizer. It modulates troponin C, activates vascular ATP-dependent potassium channels. It is used for low cardiac output state no mortality benefit when compared to dobutamine. The dose of levosimendan is 0.05 up to 0.2 microgram per kg per minute and may require a loading dose. So we finished talking about fluids and vasoactive agents, and we have a few interventions that can help in volume offloading. This could be through diuretics, whether this could be with diuretics, whether we're using furosemide IV bolus or furosemide infusion. We can also use metalazone or spironolactone if the patient is hemodynamically unstable. At that time, we use CRRT, but renal replacement therapy is a good intervention to fluid offload the patient. And I should mention here that furosemide improves medullary oxygenation and reduces progression to acute kidney injury, at least in a study that was published in 2019. Finally, a suggested flowchart for the management of patients with shock state. Of course, first thing that you need to determine the etiology, and if there's any reversible causes, you need to act on that right away, whether it's hypovolemia, severe acidosis, hypoadrenalism, hypocalcemia, massive pulmonary embolism, or any other causes of the shock state. If there is no obvious reason, next thing that you do for the patient is you need to assess for fluid responsiveness. If the patient is fluid responsive, then you need to continue with the fluid boluses. If the patient is not fluid responsive, then you start the patient on norepinephrine, and at that time, most likely you would need an arterial line to monitor and a central line to infuse the norepinephrine through it. If the mean arterial pressure is still less than 65 millimeter mercury and the norepinephrine at more than 0.5 mics per kg per minute, at that time you need an advanced hemodynamic monitor device such as transpulmonary thermodilution device. You would do echocardiogram for the patient and measure the central venous O2 saturation through the central line that you have if it is in the IJ or the subclavian. And of course, if the patient does not respond despite norepinephrine is maximized, at that time you are dealing with a refractory shock, and you still continue to look for any correctable causes. And if the patient continue to be in shock, at that time you would add epinephrine and vasopressin. Our practice is to add first vasopressin to norepinephrine, which most of the time is going to decrease the requirement of the norepinephrine. Also, you can determine if your patient needs dobutamine based on the hemodynamic parameters that you obtain from your advanced hemodynamic monitor. If there's an increase in the pulmonary vascular resistance, or in cases of right ventricular failure, pulmonary hypertension, your milrinone is your preferred agent. And of course, some of the cases would require extracorporeal life support, such as VA ECMO. Our approach to vasopressors in septic shock starts with norepinephrine. We go up to maximum 1.5 mics per kg per minute. We rarely go above 1. We consider, of course, hydrocortisone with escalating dosages of norepinephrine. If the patient is tachycardic, then vasopressin instead. We discourage the use of phenylephrine because of the increased mortality that was observed during the shortage of norepinephrine. At that time, phenylephrine was used in septic shock. If a patient is bradycardic, we use dopamine as a first agent. Now, the second agent that you add is vasopressin. It has a beta adrenergic sparing effect, and we start at a fixed dose of 0.03 units per minute. We do this once we reach on the norepinephrine, once we reach a dose of 0.25 to 0.5 microgram per kg per minute. In cases of tachycardia, it might be used as a first agent. Now, if a patient is in refractory shock, we add epinephrine, and it started at a dose up to 1 mics per kg per minute. Of course, you need to be careful that it can cause increased lactic acid. As I mentioned, we rarely use angiotensin II agents, but if used, you start at 20 nanogram per kg per minute and titrate up to a maximum dose of 200 nanogram per kg per minute. The evidence for that is very weak, but it is evolving. So in conclusion, fluid is essential for resuscitation, and you need to determine if your patient is fluid responsive or not. You need to avoid giving extra fluid for the patient. We'll see that in our resuscitation presentation. Balanced crystalloids are the fluid of choice for resuscitation. Mean arterial pressure should be targeted for 65 millimeter mercury, and you should restore the blood pressure swiftly in patients with septic shock. Norepinephrine is the vasopressor of choice, and high mortality is expected with higher dosages of norepinephrine. Thank you.